person today.
Yeah, okay. So our first item is to review the board agenda, and that will require a motion and approval by the board. So please review the agenda, and I'll take a motion for its approval.
Motion for the agenda.
Can I get a second on the agenda? Thank you. All in favor? Aye. Any opposed? Thank you. In accordance with the State Government Ethics Act, it is the duty of every board member to avoid both conflicts of interest and appearance of conflict. So thank you for letting us know. All right, our next action point is the review of our June 2025 board minutes, which are in your packet that you have. Please review them, and we'll entertain any suggestions or comments for revisions.
Yeah, since
Yeah.
I zero in it whenever I see my name.
Yeah, that's good.
It says at the top that I'm here, but then towards the bottom where it says Philip under presentations and updates. So Philip Hardin, economic services director, gave the update this morning, which is not in attendance. So it's conflictual. I had to leave early.
You left.
Well,
Okay.
so
So,
I don't know if that's important or not.
yeah, so we can,
Well, I mean, we can fix it, but there's no need because you were here.
you were here.
You just didn't, but I will put in the minutes that because you had to leave, fill
I
up.
weren't able to do it.
Yeah.
Yeah, thank you for that correction. Any other items for corrections? Take a motion for approval with that one correction.
So moved.
Second, all right, all in favor for approving the board minutes as amended? Any opposed? All right, those are passed. Thank you very much. All right, so we won't have any committee reports this time because we're meeting in person. We did not have our subcommittee meetings. And so we have several presentations and updates by our DHHS team members. And so I'll turn it over to David Swan.
Thank you all, and it is very great to be in person with you once again since last December. This is our first opportunity to do so. So it's lovely to have you in our building. I appreciate your willingness to relocate from our normal digs because we've got massive amounts of training going on downstairs right now. But the first item that we bring today for you is the HHS Board Operating Procedures Review. We are not taking any action on this today, but these operating procedures for the board by our accreditation standards have to be updated annually. And in 2024, that did not happen for the dual issues of Stoney's retirement. And then before the end of the year, when this would have been taken care of, Halloween happened and everything got massively disrupted. So we are behind on the review and any changes that you may wish to make to our board procedures. There's a number of pages in your packet about this. What we are asking is that between now and the August meeting, you review these and consider whether you agree with, disagree with, or have other amendments you wish to make. And we will ask you to act on this in August. So this is a teeing it up so that a month from now, we can make any edits to the board procedures that you may wish to make or think are wise. But doing this annual review and updated procedure is an accreditation standard requirement for us as an health.
David, just one quick question. In its current form, does it comply with the requirements of the accreditation standards?
I'm going to assume yes, but Kelly, do you have any comments on that?
Yeah, in the current form, what do you mean?
Meaning in this form, if this is the form that we approved, is it already complying with the accreditation standard?
Yes, and what we did with that is that if you, I don't know when you print it out, but if you look at it on the computer, the recommendations are in blue. And so that was a recommendation to change from the font that's directly above it. So, lots of changes recommended, more to make it clarifying and more simple. Just trying to take a lot of wordiness out. So that anyone that can read it can understand exactly what it means. So trying to go for that, but it was, the actual adopted one is, yes, it is certified, it's accepted by accreditation. The changes that are in there would also be acceptable, because it's, like I said, it's just more, clarifying language, that we were trying to go.
Great, thank you.
And I guess to Kelly's point though, in the online digital version that you were sent, there are differences in font color between blue and black. And so if you really want to comprehend the proposed changes, please review the digital email version that was sent to you before the meeting. This is just printed out of the packet as another means for me to bring this to your attention. But basically, no action today, just be aware of it.
And look at the digital version.
Look at the digital version and come in the next meeting prepared to either accept it, reject it, adopt any other amendments as you wish. That is all there. And next, we have another policy review issue that I'm going to ask Ellis to
similar topic, as you learned in your public health annual training, you all are responsible for some of our public health governance policies, and annually we have to do a review of them as well. You received in your email, along with the agenda for this meeting, I believe it's 9 public health policies for your review. If you have any feedback, if you could send that to Krista so that we can make any updates. When you review those policies, you'll notice at the very end of the policy is a revision history. And if any revisions were made, it will say the date and what the revision was. So that will make it easier for you to understand any changes that were made. And for the majority of them, the changes that were made is just be added in, back in legal guidance wording at the very end of the policy. So yes, please send your feedback to Krista and we'll get any updates made. And of course, if you have any specific questions or want to reach out to me, don't hesitate. And then we will vote on them for you to pass them so that the board chair can sign them at the next meeting. Thank you.
So the next item we have for you is an actual presentation, not just a brief one. So I want to ask Mitch Albers to please come and present to the board about our harm reduction program updates.
It's a bit of an awkward setup. I guess I'll take
Take the podium and do the best that you can.
Yeah, thanks for having me. I think probably about half a year ago when I gave the last update. So yeah, glad to be here. Just wanted to share broad updates about the past year with the harm reduction program, and also just kind of look at some of the stuff that's happening with the safer smoking pilot as well. So first and foremost, harm reduction program. So still in the process of actually officially rebranding what was our syringe service program into now the harm reduction program. So that was multi-pronged. It was an effort to kind of address the stigma associated sometimes with the terminology of syringe. For some folks, we had feedback from participants feeling kind of stigmatized around that. And then also just to better encompass a lot of the extra work that's going on now, which I'm going to go into in some of the later slides here. So yeah, rebranding involves a little more than we thought. So we're working on changing that on the web pages, got to change it on our brochures. Kate pointed out some of the internal signage. So it's a little more than just saying we want to change the name. But excited to have that change, and I think it's starting to catch on, at least internally. This year also brought 2 new contracts. I applied for and got a grant award through Dogwood Health Trust. So with that, we started 2 multi-year contracts. One is the harm reduction program care linkage. So instead of SSP, now saying HRP. So the HRP care linkage, we added a dedicated peer support case manager. So this individual is also working through Sunrise Community, which is the individuals that currently and have staffed our HRP since 2019. So brought in another staff member from there. Their focus is on supporting both our harm reduction program participants and our Hep C bridge program participants as well. So she has already taken on about 60 cases. They just started back in February. So they've already had, and I have some details later in here about putting numbers to it, but she's already started working with about 61 people. So that's caught on pretty quick and some good successes from that already to share. The second is around outreach and education, specifically targeting our Hispanic community partners. So we've had a few contracts in the past with UNITE, and so this is in partnership with UNITE as well. So back in February when this started, I did about a half-day long train the trainer session with them and their community health workers. So just kind of get them trained up, be able to kind of be champions of the harm reduction work and training people in the community on Narcan use, as well as just safer use practices and all of that as well. Specifically being able to offer it in their community directly and in Spanish. Unfortunately, I do not speak Spanish. But yeah, so that's been great so far. They come out to some of our collaborative training so they can offer training directly to folks in Spanish that request that. And then they're putting on their own events as well. So I was actually just talking to Jose earlier in the week, and they've reached about 215 adults already for training, which is a pretty great start. So I'm excited to see where that goes from here. They're also collaborating with us, and then ultimately we'll go to Cape for some outreach and training materials in Spanish primary as well. So yeah, excited to see that one come to fruition. Let's see. Just looking over here. Yeah, just touching on our Hep C bridge program as well a little bit. So yeah, last year, 145 program enrollments. Of those 145, 137 followed through with beginning treatment, and 112 were actually able to complete treatment, which is up over the prior year. So that's great to see. Adding that case manager was also kind of born out of just the sheer volume increase that we've seen. So we've seen participant volume spike over the past year, and it continues to grow. And what we're finding is that the reason people are presenting to the program is expanding as well. So prior to implementing that program, as well as some of our alternative use supplies as well, we had about an average of 13, to put this in context, 13% of all visits did not result in someone being distributed syringes. Today, it's now half. So we've completely shifted the demographic that we're serving and also the approach that people are being served. So we're shifting more to being more of a health and community hub for folks. So it's really transitioning into less of a transactional model and more of a resource hub for folks. See if I do this right. All right. Click through. So that's our, just put some numbers to it. This is our participant volume over the fiscal years. So again, program started mid-late fiscal 2019. And so 22, 23, 24, pretty stagnant. And then shockingly, adding these couple different initiatives, we have seen more than doubling the growth. So we plateaued those 3 years, pretty stagnant. And then, yeah, added the dedicated case manager, our alternative use supplies, and we are now seeing over 103% more people just this past year alone. Other things we've been working on, I put an enhanced focus on safe syringe disposal in the community. So less syringes are being distributed through our program, and also offering a wider array of ways for folks to dispose of syringes properly. So we had, I think I put on there, over 1,300 individual syringe disposal options given out to participants. So in other words, people are coming in and getting anything from a small hard case pocket pack to be able to dispose of used syringes in, all the way up to a 2-gallon little trash can size. And then also we have select kiosks installed in the community in collaboration with the city of Asheville as well. So those the kiosks bring in a few thousand each per month. So it's truly really taken off. We added one to, I think it's in here later, but we added one to A-Hope recently. That's one we've been working on for quite a while. We're adding a new one outside of Piscataway over by China Taste, State Street area, if people are familiar. And then we have other ones throughout the community that have existed for some time. What other numbers are on here? We had, over nearly 13,000 participant visits, over 2,700 unique participant visits. Of those, about 1,300 were new participants. We had 474 participant reported overdose reversals. So when people come through, we're asking them if they've had to use Narcan on any community members since they've been in last. And so that yielded 474. So with that, we gave out over 4,500 naloxone kits. And just with our own program participants, that yielded that nearly 500 community reversals. All right. Other thing I want to focus on that showed a really drastic shift was just the syringe distributed to participants. So again, looking back, early program iteration, only about 13% of visits did not result in distributing syringes. Now we're at 50%, so half and half for the reasons people are handing in. And so with that, less syringes going out to the community, less syringe waste in the community. Less syringe litter in the community. We also have a significantly more amount of our participant base opting for alternative routes of use. So shifting away from IV use, potentially smoking or just orally. So that also drives down the request for syringes, which also leads to some pretty significant cost savings for us. So even with growing by over 103% in our volume, we remain budget neutral, which is pretty impressive, honestly. So we didn't have to increase any of our supply costs because the amount of costs that goes into giving out a syringe kit is drastically higher than some of the alternative routes of use. And there's also been some tariff issues with some of our supplies. So we've had some tariff hits on aluminum and some of our other medical supplies. Unfortunately, some of our syringe disposal options are getting hit with import tariffs as well. So our syringe kiosks might have to look elsewhere soon outside of Canada, because those went up about 100%. So thankfully, we bought a couple of those last year. We have one left in the loading dock. What else do I have on here? Yeah, and also just talking with our community partners, WinCap, Collar Harm Reduction, Steady Collective, other folks out there doing similar work. I just wanted to try and mirror better the volume and supplies that other community partners are giving out. So with that, we kind of reduced how many we give out standard to each participant. And then just coupled with less being requested. Oh,
There.
thank you.
That'll help you.
I can stop looking back and forth. All right. I think that's all I had on that slide.
I have a question.
Go ahead.
The hurricane happened in the third quarter of last year. Does it have anything to do with the decline of distribution
Fair.
for those supplies needed? Which is why we say that's well, I'm just curious.
Yeah, and so this graph is by quarter. So we did, of course, have a decline quarter over quarter, but year as a whole, we still served 103% more individuals. And we did still operate during the hurricane as well. So we saw about 1,900 folks during the hurricane quarter versus 4,400 last quarter. So significantly less, but we still operated. All of the same services were still offered. Yeah, but yeah, definitely could be part of it. but it's definitely a trend quarter over quarter going down for sure. All right, so looking into some of our demographic shifts that we've seen. So prior to launching the safer smoking pilot, our participant base since fiscal 19 was predominantly white. We had a greater than 90% white participant base. 1 month in, that dropped to 78%. And at this time, we're now balancing around 61.5% white. So we've completely shifted our participant base over the past year, moving more towards a more equitable balance that's reflecting our community. Yeah, so that's been a pretty significant shift. Of note also, and again, this is only since February working with UNITE, but our Hispanic population base went from 0.4% to 4.4%. Not huge, but in the grand scheme of things, it's a pretty significant jump in a short frame of time. Secondarily, I was also interested in looking at the age distribution. So interestingly, we saw an 80% increase ages 55 to 64 over the past year, which historically was a very small segment of the folks we served, as well as the 65 to 74. My assumption here would be that our older participants are already shifted away from using IV. When I worked in the hospital, that's a trend I definitely saw. The folks that came in that were over 55, kind of in that category, were not using IV. They were either smoking or using orally. And so I think now that there's different offerings in terms of the route of use and supplies offered, I think we're tapping more into that demographic as well. I don't have that direct answer. We didn't survey it, but that would be my assumption just based on what I've seen in the past. And yeah, sample size down here is about 1,200 folks. So this is just based on intakes. So this is 1,143 intakes over the past year. So we're taking the demographic information at the time of signing them up for the program. Just to look at some things by the numbers, participant and community highlights. So participant support highlights, we linked 28 folks to STI/STD testing in-house. We directly linked 43 people to substance use treatment, 21 to mental health treatment. So this is physically taking them out of the building and taking them into the community to go to these services. 664 one-on-one peer support engagements. Just to kind of further define that, that would be one of our peer support staff kind of taking one of the participants off to the side, either just kind of lending a listening ear, empathizing, making plans around individual goals, treatment options, kind of runs the gamut. But that's just beyond that transactional interaction, taking the time to go into a room with them, sitting down, talking through plans with them. Again, 61 initial intakes with the case manager. I think we're going to continue to see more and more traction there. Just under 200 individual social determinants of health supports. So tapping into some of the opioid settlement funds and being able to help out some of our program participants with things like entry fees to safer recovery housing, getting on MAT, purchasing prescriptions, bus tickets out of town, things like that. It kind of runs the gamut. But that's been really cool to see and something that I'm working on a roundup to present on as well. And then 84 miscellaneous referrals. Miscellaneous because it's 1-2 instances of something. It'd be too much to throw up here on the board. But that has looked like things like linkage to DV supports, medical specialists, parenting classes. Yeah, kind of runs the gamut in terms of what all those extra supports are as well. Community initiatives, continuing to do monthly drop-in trainings here at HHS. Now doing that in partnership with UNITE, which is going really well. We added a monthly training at AmeriHealth as well, second Tuesdays of the month. We're doing a training with the FJC building partners next month. Excited for that one. Going to be doing a training series with the housing authority staff. I believe that's in August as well. Again, collaborating more with City of Asheville to increase disposal options. So the one going in on State Street shortly, and then hesitant to announce yet because we got to work on some MOU stuff, but some other things in the works in terms of installing more. As well as getting some more Nalox boxes out there. I don't know if I mentioned those to the group prior, but the Nalox box is basically like an AED housing box. It's an opioid response kit. So it has a pack of nasal naloxone in it, a CPR mask, gloves, and little tearaway instructions. And then it gets tagged like a fire extinguisher. So it's not just a free for all. You can't just open it up. You have to rip it open. And anytime we get those installed, we do a training in tandem with the organization that it's going to make sure they know what, what they're installing, how to use it. So yeah, hopeful we're going to be getting some of those into more of the HACA communities as well. I was just meeting with their new COO earlier this week about that training and also some of these opportunities as well. And then we've also been focusing more on substance testing. So we partnered with UNC Chapel Hill. They have a drug lab where you actually collect samples, not in-house. We have our staff in the community that have collected samples from program participants. Those get sent off to Chapel Hill. And it takes about a week turnaround, unfortunately, so it's not real in the moment results, but it gives us kind of a glimpse on what we're seeing in the community in terms of the street drug supply. And it's not great, some of the things we're seeing in the street drug supply. So, of course, we're seeing more and more xylazine out in the community and those associated wounds. So we're stocking more and more wound care supplies, referring people to wound care and helping out with port as well, so that they can follow up with them in the community. Some of the main adulterants that we're seeing for folks that may have more of the science mind around it, we're seeing the xylazine as well as medetomidine, which is another veterinary medication. They say it's up to 200 times more potent than xylazine. So it's unfortunate we're starting to see that in the supply as well. As well as just a bunch of different adulterants. So BIS sebacate, which is an industrial plasticizer, is showing up in most of the samples that we submit. As well as 4-ANPP, which is a precursor to manufacturing fentanyl, which also is very toxic. So we're seeing more and more contaminated samples out in the community. Roughly, when we submit a sample, there's usually 9 to 13 different substances. And this is people submitting things that they think are pure, or that they got from a trusted person or someone they've been to for years, and still coming back with over a dozen different things in it. So really just emphasizes the importance to have that informed use practice. So trying to do things like make sure we have test strips for the different substances out there. So we do have fentanyl, xylazine test strips, and then they just came out with the nitazene test strips. I was able to get those last week as well. But ultimately, what will be most beneficial is being able to test in the moment and have those results. Unfortunately, those machines are very expensive, but might be able to source a grant at some point to try and look at working on that. If anybody's interested in looking at some of the UNC results, it's public facing website. I think it's uncdruglab.com. And then we also submit stuff to Street Check, which is an independent website as well. But yeah, you can sort by Asheville, you can sort by region. It's pretty eye-opening to look at what's out there.
Rich, can you comment though, the new substance mixes you're seeing? What kind of risks are there about naloxone being less helpful?
Yeah. So of course, naloxone works on the opioids, right? So it works on fentanyl, heroin, which we don't really see anymore. But it doesn't phase xylazine. So xylazine's kind of been that recent emerging threat. And then now things like medetomidine, even more potent. Really the only support, it's supportive care with the tranquilizers, which is what xylazine is. So more important than ever to link people into medical care so they can do the supportive work around it. Yeah, unfortunately, there's not a readily available reversal agent that we can stock for the tranquilizers. So, yeah.
It's interesting you say that because in veterinary medicine, we use a lot of medicine, although it's also a human drug, is a major ICU.
Yeah.
Precedex is the brand name for
Oh, okay.
humans. For dogs and cats, there is a reversal agent. It's
Okay.
called atipamezole. It almost instantly.
So just not approved for
reverses.
human use?
And I talked to the guy at UNC about this, and he said in humans in case studies, it can cause a massive rebound hypertension. But I'm not sure if rebound hypertension is worse than suffocating. I mean, it's kind of mind boggling to me. I can't really find any answers as to why the reversal agent, which
Yeah.
you cannot buy a bottle of it in a vet clinic without them shipping the bottle of the reversal agent.
Okay.
But there's not been more testing of this in people. It seems like a fixable problem.
Yeah.
Not that you're gonna fix it during this meeting, but I mean, it's just very strange.
Yeah. And yeah, you'd think it'd be a little quicker. The tranquilizer agents really started showing up in the supply up northeast around 2020. And it's kind of worked its way down the eastern seaboard. So we started seeing it here more in 2022, 23. But even with that, you would think they'd be working on getting something out to the public quicker. Before it just shifts to the next emerging threat. Yeah, which is what we've seen. It's like we started to get a handle on dealing with fentanyl, and now it's barely fentanyl anymore. So that's another thing the street check tracks as well, as we're seeing kind of the ratio of the substances shift. So we're seeing more and more of the sedatives and less of the opioids. So,
And as far as I know, the way these are entering the drug supply, these are not like being diverted from vet clinics. These are,
yeah,
people are buying like bulk research chemical.
Yeah.
China and stuff. And
Yeah. People trying to play chemist and manufacture. Yeah. I think that's my last slide. I wanted to share a couple success stories though. Just early on successes that our case manager passed along. So our case manager describes, they use the name Steve as a very inspiring, motivational individual. They lost their home and car after the hurricane hit. Ever since the storm hit, they've been struggling to get back on their feet and had a significant return to use as a result. After engaging with the case manager, ultimately they decided to enter treatment, and they were directly linked to detox and then moved over to rehab. Once he was released, he came back to see us and was talking about taking the next steps in getting back on his feet. We were able to get him in touch with a past coworker who lived outside of town and owned an auto shop, which is the industry he used to work in. He was able to connect with a friend out that way and started to stay with them and was hopeful to earn a few paychecks and get his own place. Unfortunately, a few days later, we saw him again, and he was crying, saying it didn't work out and that he felt defeated. But he remained dedicated to success and continued to engage with us. He was able to work on job applications and one day came back in ecstatic to tell us he had an interview at a local shop and actually got the job offer. So we were able at that point to help him get some clothes for work, some steel-toed boots, and has been able to since start working. So he's still in recovery now, comes in to see us, even though he doesn't need any of the supplies that we offer, just to check in. So he's truly a testament to perseverance in the face of adversity. And he told us, quote, even when something doesn't go as planned the first time, doesn't mean something even better isn't right behind it. So I was excited to share that one. And then we had someone they called Will that we've known since the early days of this program. And folks have known even longer just out in the community. He's described as the type of person who'll do anything for the folks around him, giving his own clothes off of his back, letting people use his tent. He's been unhoused for almost 20 years in the Asheville community and told us for a long time that he'd rather live outside because it's what he knows and he doesn't feel trapped by the walls. But flash forward to today with some motivation. He's about a month to a month and a half out from getting housed for the first time in Asheville, thanks to some advocacy from the team. And he's getting connected to needed resources, is engaging more and more with us. And we're working on pulling together some housewarming things for him for when he finally gets housed. So really excited to see 20 years on the street is a very long time. So really encouraging to see somebody enter their own housing after that. And then more broadly, just wanted to share, we've seen in the past year what we would call a few full circle peers come through with the program. So everybody that works in the program is a peer support specialist, so lived experience with substance use and mental health. And so we've had about 3 or 4 interns in the past year that have been former program participants that have been in recovery for 2 or 3 years at this point, that are now, come through and interned and volunteered, got their peer support certification, and, taking that next step to work in the field of recovery. So really cool to kind of see now with this length of programming, going back to 2019, be able to start to see people that we were serving now working in the same field. So didn't want to put names to it. One of them said they were comfortable with it, but just wanted to share that as well. But yeah, time for questions if there's anything else.
If we're out in the community, how do we refer someone to these services if we're?
Yeah, it's walk in, they're open downstairs 12 to 4.
So,
And
it's in this.
Yeah,
building.
lower level down by communicable disease. We try and keep it as anonymous as we can. Of course, if somebody wants to work on case management, stuff like that, we're gonna have to get their information. But that is one of the hooks for folks is we keep it anonymous. So they can give us as little or as much information as they want. But yeah, low barrier, obviously free of cost. All we, at a minimum, just need initials, date of birth.
Amy Brown, legal billing for Kurt.
Yeah.
Is there a way to make a donation for people like this person's gonna get their new house and I want to give them off and bed? How would you do that?
We do keep some random supply stuff, like I brought in a Keurig that I didn't need, so that's gonna go to them. So we have a supply closet downstairs. We might not go directly in hand to them, but we do try and keep stuff like that. We have some plates, pots and pans, yeah. It'd be great. You can reach out to me.
I just want to say thank you, Mitch.
Yeah.
I mean, this is an amazing program. Know that you care about it.
Thank you.
Which is a big deal whenever you want to population of people. And I like where it's headed. It looks like it's becoming more holistic.
Yeah.
And the numbers look good. Keep doing the good work.
Yeah.
Thank you so much to you and your team.
Thank you.
Thank you.
This one of the boards, before showing, but how many of the members of the board have had naloxone training?
Yeah.
So is that something that members of the board would be interested in? At one point, we had expressed an interest in doing the training as a board, and that actually would be nice to be out for the health department with the board of health.
Yeah.
Doing naloxone training.
We could definitely set that up.
So would anybody be interested in doing that as board members? Perhaps as after a board meeting, follow early sometime?
Does it need to be in person?
Ideally.
Okay,
Yeah, so I have little training devices and stuff, so it'd be.
okay, so maybe at our next in-person meeting in October, we could have that either before the meeting or after the meeting.
That's great. So we can take that to the executive committee and we'll work with the, with David about scheduling that for board members.
Does that need a proposal to go to the?
I don't think so. I
Okay.
don't think that's a suggestion from a board member.
Okay.
That's great. Thank you.
And then one last shameless plug, if any of the organizations you all represent are interested in anything I described, like having in the locks box, having a training with your organization, safe disposal options, anything like that. We have most of those things in abundance. If you want to, and of course, naloxone. We have plenty of naloxone. We have a whole closet full. So if you need any in bulk or community partners that might want it, just let me know.
How long would it take you?
I get that one a lot. Could be anywhere from, I do ones from, 15 minutes, very crash course, up to hour and a half presentations. Kind of whatever feels right. 15 minutes would be very much like, here's the product, here's how to use it. Hour and a half, I can go into harm reduction principles and, some of the stuff I talked about today, like what we're seeing out in the street. Get more into the weeds with it.
Thank you, Mitchell.
Yeah, thanks, Al.
Thank you.
All right, so our next presentation is from Philip. Giving us an overview about what you're seeing and understanding from the new federal legislation. How it affects us.
All right. So I want to start out with just saying that large overview, 50,000 foot level, maybe. There's so many unknowns right now, the variables that play out with this about how it really falls out at a local level or a state level. A lot of it's based on what maybe the General Assembly does do or don't do. There's, I know David and I talked some about assumptions about trying to look at staffing levels and those kinds of things, but it's really, really hard right now to even strategically make it.
Could you just speak up on this?
Really strategically make any kinds of any kind of assumption. I've done this work for a long time, and I'm usually pretty good at making guesses or assumptions about how things play out. I don't have a clue. I mean, I'll just say, because there's so many variables that can happen with all this legislation. And so,
You were working on it. There we go.
So, and I hate to say it, the bill's over 1,000 pages or so. And we went through it. I will give kudos to Ian Allen, who's a Medicaid program supervisor, and looked through this bill and tried to pull out some of the major things in the bill. But in essence, there's things that are buried in this bill, I think, that we've not seen. I still have questions about the energy program. And, I don't necessarily have anything to give you about the energy program other than it looks like it's still there. We just don't know how much money's there. So, but want to talk about SNAP and Medicaid, because those are the two main programs that we'll be dealing with. So let's start. Increase in work requirements. This is for SNAP, or what we call Food and Nutrition Services in North Carolina. Right now, let me kind of explain this a little bit. We have a policy now and have had since 1996. We call it able-bodied adults without dependents, or what we've referred to as ABODs. And that policy has been in effect since the Welfare Reform Bill of 1996. And what it basically says is that if you're an able-bodied adult and don't have any dependent children, then you can only get food assistance for 3 months out of a 36-month period. Unless you're working or doing community service or volunteering or doing something like that, 80 hours a month. And since 1996, that policy's been in effect. Sometimes it's not. There's rules that it can be waived, suspended, and when your unemployment rate gets above 6% or so, it used to be, you could waive that rule, and the state always waived it. During the pandemic, it was waived for years and years and years. It was waived from 2007 when the recession hit to 2015. We didn't implement that rule. It is back in effect now. And what this does with work requirements for food is it adds on to that. Right now, if you have a child under the age of 18, you're exempt from ABODs. This now phases it in if you have children you'd be exempt if you have children under the age of 15. And it moves the age limit from 54 to 64 that it applies to. And it also narrows the exemptions. In the past, if you were homeless, that's an exemption from the ABOD. With the new law, it's not an exemption anymore. The only exemptions that really exist for ABODs will be basically disability and pregnancy. So it really brings in a lot more people who will be subject to work requirements. And what that means is that after 3 months, if you're not doing those 80 hours, then you're cut off for 3 years. And the only way you could come back on would be that you're working 80 hours or you're doing community service or such.
Actually very much interest to me with the folks we serve, and I'm curious, I heard community service, did you say volunteering too?
Could be volunteering, yes.
How's that all there?
That is another
To be determined.
administrative burden that it will exist with our staff. And there is another change with work requirements too, and it goes with Medicaid when we'll get to work requirements about Medicaid. In essence, in the past, if you came back in, it moves that work requirement up front. I mean, in essence, we had approved applications and then tried to verify that information in the past. If now you have to verify it before your application will ever be approved. Increased administrative cost. Right now, for staff who work in food assistance, it's a 50-50 match, 50% federal and 50% county. In North Carolina, because we're county supervised, state administered, the county pays the administrative share of that. That changes to 75% county or state and 25% federal in October of 2026. We'll talk about what that looks like in Buncombe County in a minute.
So getting back to the work requirement, the burden of proof lies on the administration, and the administration is getting 25% less funding to support the administration to verify the work requirement on the people who need it.
Well, what I'll tell you is, yes, there's a lot of variables that go into this. Probably our caseloads will decrease, but our administrative burden increases because there's lots of things that are in the policy that add to the work that our staff already do.
And your funding to administration is decreasing.
Yes. Shifted cost of some of the benefits. Those are the benefits that people receive for food SNAP. It's always been since SNAP existed that the federal government has always paid 100% of those benefits. This shifts that burden to the state and or county or both in October of 2027. We'll talk about numbers in a minute. All right, so as a state, estimated 9,000 adults will lose SNAP benefits. The cost sharing for administrative costs is $65 million a year for counties right now. And then up to $420 million per year for the state or the counties for the benefits. In Buncombe County, we estimate we would lose about 1,800 individuals or cases to work requirements. That cost sharing in Buncombe right now as it stands, we got 2.47 million on there. It's actually a little bit more than that. If you look at just our food staff, it's not just our food staff who code to food assistance. There's a whole bunch of staff in HHS that are cost allocated and draw down some revenue out of food assistance. Myself, I don't do food assistance, but I manage a food assistance program. So some of my salary is cost allocated and paid for at a 50-50 match. So in essence, really that number right now as it exists is about $3.5 million for Buncombe County. Our front desk staff, some of their salary is paid for out of food assistance revenue. Our call center staff, our finance staff. There's lots of people who are, Christus draws some money out of food assistance.
Why is that happening that way?
Because when you're over multiple programs, a lot of managerial staff and administrative staff, because we run public assistance programs, can be cost allocated. A small percentage of their time is revenue used.
Basically, the thing about it, in the nonprofit world, there's an indirect cost rate.
Right.
This is the indirect cost
Right, for government.
for government.
Correct.
But with these reduced federal shares, that percolates throughout the entire budget in terms of impacts. As the federal cost share goes down, it increases the proportion of funding the county or state would be expected to add to maintain status quo.
I mean, in essence, because of that cost allocation, that 75%, 25% becomes more like 79%, 21%.
So it gives you the flexibility to kind of juggle the numbers and are the allocations to where you actually need the funds.
Well, it helps us offset our staff cost with revenue from the federal government. It helps offset county costs for a lot of staff who work for HHS, not just food staff.
Another way to say it is it pays for infrastructure.
Yes,
Yeah,
You know, it's not just programmatic. I mean,
Correct.
If the SNAP thing just went away, you stopped providing, the cost loss would be greater than just the program cost
right.
that is
on the
correct.
whole system.
Right, because you'd be losing the direct line and the indirect line.
Yeah.
Mhm.
You're losing both.
You lose both. And what Philip was just describing is that, what it means is that the 75-25 split, that's in a perfect scenario. But they wrote into the law that if the error rate on transactions process exceeds different thresholds, it lets the federal government reduce their cost share even more.
Right.
And we have to apply the entire state's error rate to the cost share formula. So it's not even just locally based, it's the entire state of North Carolina's error rate would lose us 4% more in the cost share. So it'd go down from 25 to 21. In other words, it'd go from 75% to 79% state and local share. Go up.
So that 3.5 million may become more. And that goes for the cost sharing for the client's benefits too. The way it exists right now, it's based on an error rate also. And so it's like, if you're under 6%, and I believe there's 8 states in the country whose error rate is under 6%. Between 6 and 10, you say pay a certain percentage. of the benefits. If you're above 10, you pay a higher percentage of the benefits. And if you're above 15 or 18 or something, then you pay a higher percentage. It could actually go up. Right now, the way it stands based on our error rate from 2 years ago, or last year, state error rate was right at about 10%. Talking $420 million for the benefits.
Two questions. One, wasn't there something about the Alaska, they got, that it's somehow like,
They didn't get exempt. That there was a number of states who had horrible error rates. They're off the chart. They're like 25, 30% error rate. And a lot of those states had Republican legislators. And they got a vote from those Republican legislators because they get another 2 years of a waiver before. Yeah, it's a waiver for the worst states error, the worst 6 or 7 states error rates got a waiver for an extra 2 years before this takes effect. It is done by the state. What happens is we're mandated as a state to calculate error rates. And the state has a quality control team. And they don't read a lot. It's a very small percentage of records. I mean, I'll tell you, small counties, they may have 1 record read a year, maybe 0. So think about that as a small county. If you have 1 record read and it's wrong, your error rate's 100%.
Wow.
If it's right, your error rate's 100%, or your accuracy rate is 100%. We'll have probably 20 to 25 records read a year. Now, internally, we read a lot more cases. But that does not count toward our state error rate. And so they'll only read probably 500 to 750 cases a year across the entire state for 800,000 food assistance records. And then they report that to the federal government. And then the federal government does a QC on our QCs. And so that whatever we report can be adjusted at a later time by the federal government.
The last thing is, this goes into effect October 2027.
We'll get to the time.
Okay.
So, I think the note at the bottom is important. And this is something I will tell you that I did not know. But until we started having these conversations, apparently this states, any state, can opt out of running a SNAP program altogether.
Is that new?
I don't know that it's new. I don't think anybody ever thought about it because they didn't pay any of the benefits.
Mm-hmm.
But now all of a sudden it has come up because now you have money in the game.
Mm-hmm.
And but I did not know it was an option because I always considered SNAP as an entitlement program. But apparently it is an option that you can say, we don't want to run a SNAP program. There's
Who would make that determination?
the General
Well,
Assembly.
I know the General Assembly, but I guess I should have been more succinct in what I was asking in terms of county governments.
Well, we won't have a choice. I mean,
Yeah,
because
because of how-
let me go back and talk about how that works, because the federal government does not care that this state is state supervised and county administered.
That's what.
They deal with the state and the state only. They don't care about counties. Because their contract for programs is with the state.
So is gonna be an agency decision or a budgetary decision?
My guess will be it's a General Assembly budgetary
So
decision.
the General Assembly, when they approve a budget, whenever they approve a budget, they will make the decision whether they're appropriating funds for staff. It's not up to the state DHHS to use their budget for this or not.
It's not discretionary.
It's not discretionary. Yeah.
The thing that states must do under this legislation is by October the 1st, 2027. They have to indicate whether they will have SNAP in their state or they won't have SNAP in their state. If they do continue SNAP, they're accepting the 15% cost share under the legislation, which kicks in October 1st, 2027. So the General Assembly has from now until then to decide whether SNAP continues or discontinues in North Carolina. Now, that's on the benefit cost share. What is not required, to Phil's point, federal government does not care how North Carolina structures things. So the cost share reduction by the federal government from 50% to 25%, they do not care what happens at the state level. And there's no requirement on North Carolina to pick up any portion of that share. There's just a reduction in the federal share. And so internally here in the state, we have two advocacy fights at least. Just on SNAP, we haven't even got to Medicaid.
Yeah.
No, so just on SNAP, it's trying to convince the state to not pull out of SNAP. And trying to convince the state to help the counties pay for it. And all of that is a political fight involved.
And there's variables within this. I think the question's been asked. If we had to pay 15%, could the state keep SNAP and just not pay that 15% and only give people, the residents, 85% of the benefits? Because what you have to understand about SNAP is the General Assembly really has no real authority on the rules for SNAP. They're federal rules, which means they can't dicker with the rules to say, let's make this so hard that only certain people, a quarter of the people who get SNAP can get. They don't have that authority. It's a federal program and they have very little leeway with changing the policy to restrict it to people. But so there is, some thought. There would have to be a lot of legislative changes to do something like that, though, because it's an entitlement program. They're entitled, the benefit levels are set at the federal level. So I don't know how you would make that happen unless there's change in federal legislation. Yeah, Martha.
So all this, we've been doing all this discussing about adults getting SNAP, right? And so if the General Assembly decides, hey, well, 50% cost share, blah, blah, blah. But then if they end SNAP, that means end SNAP, ending SNAP for everybody.
1.4 million North Carolinians.
Babies, kids, everybody, not just.
And it has a trickle effect on school lunch programs, it has a trickle effect on the WIC program,
This is ludicrous.
You might want to move on to Medicaid.
Yeah. Y'all gonna have to keep an eye on the time.
Okay.
This is.
Okay, so Medicaid. Adds the work requirements, the same as SNAP, basically. The 80 hours a month. Exemptions for medically frail, pregnant, caregivers, or children under the age of 15. This is the one that bothers me the worst, changes provider taxes and state directed payments. It's estimated to cost providers in North Carolina over almost $50 billion over a 10-year period. And so that really concerns me about our healthcare system as a whole. You know, most of the cuts come from the hospital expenditures. Then cost sharing fees for expansion groups where doctors' visits could be up to $35 a piece for our people on Medicaid. Whereas right now they pay $3. That's a large change. And then retro Medicaid coverage. Right now it's 3 months. Somebody comes in and applies in this month. We could go back 3 months and pay medical bills in those 3 months. That limits it to 2, and for expansion Medicaid, only 1 month. The hospitals use retro Medicaid a lot to help offset really large medical bills. So
Some that have mass have started long before 1 month.
yeah,
You have a $500,000 hospital charge that started 2 months ago. And you apply to Medicaid extension, you're not gonna get anything.
well, it's for mainly for people who didn't qualify for Medicaid in the first place. So North Carolina's a state. Almost 260,000 lose Medicaid through work requirements. Loss of funding could trigger Medicaid expansion to go away because of the provider benefit tax, which takes effect right away. Right now, we have over 17,000 expansion cases in Buncombe County alone. Numbers for Buncombe County. Here's the doubling of the research. Like now we only do recertifications every 12 months. This goes to every 6 months. And that goes in December of 26. And all kinds of Medicaid screening requirements that we don't do now. So once again, administrative burden. Refugees and asylees, right now, they're eligible for benefits. This limits their ability to get that. And that goes into effect in October 26.
Another question. Heard that getting declared disabled is very expensive and hard.
Getting,
Declared disabled, so like you could have somebody who actually really is physically unable to work, but also does not have the means to declare disabled. If we didn't have a program for that.
depends on which program you're talking about. If you're going through Social Security, yeah. It also depends on how they write the policy. Right now, we can just take a regular doctor's statement for both of them. Most of our programs,
Oh, so just a doctor's statement. Okay, so then I feel like a lawyer.
unless they do away with that, that's the way it exists right now.
Just as a caveat, most doctors won't do disability assessments. It's too difficult. And it's too, it needs too much legally. So there's special disability doctors. You know, that work.
Like there's special disability lawyers.
Yes, that's right. So yeah, it's not easy to get disability.
Affordable Care Act changes really are basically a lot of subsidies that were provided during the COVID era, where people, basically a lot of low income people paid nothing for ACA coverage. They've gone away, and there's some repayment in there.
Do we have an estimate of how many people that will affect in Buncombe County at all, who are on the ACA coverage? No, we don't know that number.
We don't track ACA data.
Because that's gonna be another tranche of people that, I mean, it was hard enough to convince people to get ACA coverage in the first place.
Yeah.
And now it's just that basically the gap is gonna.
And especially that's been going on for 4 or 5 years.
And could I add something real quick?
Um,
With the Affordable Care Act, my understanding is the bill also eliminated the premium tax credit that affected the people who were getting the insurance through the Affordable Care Act. So no longer will that be credited to their tax burden. It'll be actually a tax increase for them if they were to maintain their coverage. And so that over the next 10 years is going to increase taxes by over $500 billion. And a couple who is 60 years of age, who earns $80,000 a year, is going to see an increase in their health care premiums of $18,000 a year. So on top of the people who are in need of Medicaid, you have another layer of American citizens who are just getting crunched as well.
Main thing here, the admin costs, 2026 of October. Expansion twice a year. Error rate cost share October 27. And state directed Medicaid payments, 2028.
Mr. Harden, thank you so much. This was, I think, a heavier topic. I mean, we're all still learning through this. So thank you for such a great presentation. If I have anything to add, I would like to ask you, what can we be doing as a board in preparation or to advocate in the now, knowing that we have a year and 2 years on some of this before things come into effect?
I think the advocacy needs to be directed toward the General Assembly. I would advocate for them to pick up the cost share.
It's been advocated, the Buncombe County have a lobbyist.
They do.
We do.
And the county is a whole, I mean, this is a burden not only for Buncombe County, it's a burden for every county in this state.
But I wonder, so as Buncombe County Commissioners, we do have a lobbyist. Maybe we can add that to our legislative agenda. I can send an email and ask about it. I don't mind.
That was gonna be leading into my report. So in terms of, so what can you do? Exactly the point. So, yes, the whole fight now, federal fight's over. One big beautiful bill act, both houses passed, president signed, it's gonna be the law. So now all of the advocacy, all of our energy and direction has got to be internally focused within North Carolina or the General Assembly, but also internal discussions with county commissioners, frankly. But what can you do is you can certainly, first of all, stay informed. I know it's hard to stay informed, and we'll do everything we can to facilitate that. But please make every effort on your own as well. And please consider your advocacy options relative to our state senators, our state representatives, et cetera. And then also pay attention to the rulemaking processes. And the Department of Health and Human Services federally has until June of 2026 to publish their guidance rules. And then when they get their guidance rules, they'll pass those to the states. The states will have to write local guidance rules. So the devil's in the detail. It's a 1,000-page long bill. I have no idea how many hundreds of thousands of pages of regulation will go with it. But to the point about regulation, Dan brought something to our attention that I wanted to raise in my report to your attention about the federal government is seeking comment. There's a comment and review period on proposed regulations from the Department of Health and Human Services, basically in short, to ban undocumented immigrants from accessing any taxpayer-funded programs. And they are seeking comment to a variety of things. This is in your packet. It's a press release, but there's a link in the press release where you can go in and make your comments known. And we would encourage you to think about it because, and Dan, you can feel free to speak to this as well, but what are some of the potential impacts, right? If we say a program is federally funded and you must verify a person's legal status before you can provide services in the area of communicable disease. And that person trying to get services happens to have measles or tuberculosis or any number of other communicable diseases or sexually transmitted diseases or whatever. And we introduce a barrier of verifying your status or we can't serve you, then you don't get served. But who bears the burden of the problem? Well, the community with unregulated spread of measles or TB or, et cetera, et cetera. You see where this can go wrong. And so we were just ask you each as an individual, not as a board action, to read through this, offer any comments and feedback during the public comment period before it closes. That is a request. We'll also mention that we have received the Casper survey results that was conducted in June. And the state is working right now on the analysis. Ellis and I and others have seen some of the raw data from that, but the data report will be forthcoming and you will get a presentation about the Casper analysis similar to these presentations today in a future board meeting. And I just want to say really thank you to our social work team who is going through Path NC training and preparation for a massive culture change and technology shift in the way that they do their work. There's a tremendous amount of training that has to go on, and it has to be compressed into 8 days, and every social worker has to go through that training. And we are supposed to go live August 11th with this new software. Light a candle, say a prayer, say thank you to your local social worker for all that they're going through, because they are truly going through a great deal. So I'm keeping my remarks brief. Dan, yours, please.
Yeah.
Good question.
Yes,
When is the deadline for the comments? Do you know?
it is in the press release.
30 days.
30
days, so July 10th is when this will out.
So August 10th would be most likely, but I would try to get it in before then. But any comments you have, send it to HHS. They're asking for them.
So the chairperson's report, I'm not going to add too much, we're out of time, but I do want to thank you all for being here and being a part of this board. I think that the information that is being shared is factual and important for us to understand as board members, as representatives of our county, to both be personally informed, but really to inform others. It's so confusing out there. There's a lot of misinformation, misunderstanding, and being clear and concise about talking to our neighbors, our community members, our colleagues, about how to understand what is happening and where those advocacy points are, where those decision points. I think that's our role. So thank you for being a part of it and really trying to digest this to understand it so we can be good purveyors of information to others.
Exactly to that point, I wonder if Kate has a role in helping not just this board, but everybody who deals with HHS in Buncombe County, lists of talking points as things roll out, because you're right, Philip, there's so much we don't know yet. But if there are really powerful bullet points that we could have a list of to share with our community. Because this is great, but I'm trying to figure out how to translate this from the meetings.
We'll take it under advisement. I mean, I think it's a broader discussion. It is complicated a little bit because some of the guidance hasn't been written yet and won't be for months. And so much depends on what the General Assembly does or does not decide.
Right.
That it's a little difficult to craft those strong talking points, but we can certainly, please. I mean, our advocacy abilities are limited as staff.
Understood.
Yours are unlimited as a board member.
But anything
Is that a
that
simpler way to
you
say
can
it?
do to help.
I think you said it.
Yes, adequate. Yes.
All right. anything left before we adjourn?
I think I heard you maybe Chris say earlier, our next in-person is October. So August is Zoom and
September.
Yeah, we'll be back on the, every quarter, in person. All right, can I get a motion to adjourn? And a second. Adjourn. Thank you very much. All in favor, stand and.